Welcome, everybody, to the November 10th meeting of the IMAG-MSM Working Group on Multiscale Modeling and Viral Pandemics. Very grateful to you for coming. We have a pair of speakers who are going to be talking about vaccine-induced inflammation, which is a topic I think of great interest. As always, I need to remind people that this meeting is live streamed and recorded and made publicly available. So please do keep that in mind. As always, Tom Helikar and myself, Jim Sluka, Lorenzo, and Joel are available to deal with questions, comments, suggestions. We would very much appreciate your help. We have our usual communication channels. If you help us use the communication channels, we can have bigger audiences for our great speakers. I remind you that we have our YouTube archive of speakers. We have 130 some people talking on the YouTube archive. Please help us take advantage of that. We have a Twitter tag, MSM Viral. People use that. Maybe it'll help. I'm not sure Twitter right at the moment is the most effective way of communicating, but never know. For December 8th, we are going to have our slightly delayed second year discussion about the future and past of the working group. There is an IMAG-MSM page about this. There is a slide deck to which we would love to have you contribute. And also there is a survey that allows you to give us some information very quickly. Tom has just put the link to that survey in the chat. So if you would help us distribute that, it asks you basically if you've published papers in collaboration with people in the working group, if you've written grants with people in the working group, any way that we can identify whether the working group has been helpful to you in your work, that would be great. The survey itself is very short. You could always give us additional information, but the idea was to make it as painless as possible. We have a steering committee meeting tomorrow morning at 11 a.m. If you think you should be on the steering committee and you're not, and you need a link, please tell us and we'll send it to you. As always, we appreciate your participation. A big part of the steering committee this week will be trying to prepare this presentation for December and thinking about the future. Are there any other announcements that people want to make today before we move on? Okay. We have 3 talks scheduled before the end of the year. Another corporate talk next week from Nova Discovery, a week off for Thanksgiving, then the talk by Baylor on December 1st, the discussion on the working group on December 8th. There's a possibility of a December 15th meeting if people would like to suggest a speaker. As always, we have a Google form for you to suggest speakers. Please do help us come up with ideas for people for seminars. So I don't want to take more time away from our speakers. Today, we're very pleased to have 2 scientists from physIQ coming to talk to us about vaccine-induced inflammation and clearly about how you do patient monitoring to determine that, which is going to be, I think, a topic of great interest to people interested in doing digital twin development. So I don't do elaborate introductions. I don't want to take more of your time. I will turn it over to you.
Great. Let me share my screen. Hopefully you're all seeing it there.
Yep.
Good. All right. So I'm Steve Steinhubl. Thank you for the opportunity to join you. I wear multiple hats and it's confusing. So one, I'm a cardiologist. So I enjoyed the conversation we had going into this and agree with all the comments going back and forth around kind of our lack of understanding and variability and the like. I'm actually a professor of biomedical engineering at Purdue. That's kind of a brand new position for me. Before that, I was at Scripps Research. And I also serve as the chief medical officer at physIQ, a data analytic aggregation company out of Chicago that I've only worked at. I've known them for 7 or 8 years, worked on several research projects together, joined them as their chief medical officer a little bit less than 2 years ago. Whereas my colleague Stephan Wegerich has been there from the beginning, and in fact before the beginning. Stephan is the chief science officer, so he's going to answer all the hard questions today. And he did all the development work that led to the digital biomarker and what we'll talk about. And I'll focus on the clinical aspects of it. But because we have a small group, please, if anybody has any questions, feel free to interrupt me at any time. Okay, so this is just and I'll go through this quicker, maybe just to more summarize the clinical aspects of it, but these are the kind of the main things I want to cover, a little bit on reactogenicity, inflammation, immunogenicity, wearable sensors, and all that, but I'll highlight that as I go through. So begin with just this reactogenicity. So I think, as everybody knows, that's the expected set of reactions that occur after a vaccine that are believed to be the physical manifestations of inflammation. And we know that that's common, and that was especially true. I think everybody experienced it in COVID. So these are data from the VSafe study, and we're going to focus pretty much on just the systemic reactions. So kind of flu-like symptoms, fatigue, myalgias, chills, that like. So with the mRNA vaccines, about 50% after the first dose, and after the second dose, closer to 70% of people had these complaints. And this is one measure of inflammation, is just tracking the subjective complaints. And frankly, that's what historically has always been done. The challenge with that is, and this was a really nice study done within the phase 3 trials of the mRNA vaccines, is there's a nocebo effect. So the effect that comes when you tell people that they're going to get a treatment that may make them feel poorly, they're more likely to feel poorly. And so looking at comparing the side effects in individuals in the phase 3 trials of the mRNA vaccines who either got the active vaccine or placebo, that the individuals in the placebo arm had about half of the rate of systemic reactions as those in the active COVID arm. Or COVID vaccine arm, suggesting that about half of systemic complaints could be attributed to this nocebo effect, that people, when they get a vaccine, are anticipating feeling poorly, and they tend to feel poorly. So the subjective complaints after a vaccine are not a great measure for the actual inflammation that occurred in somebody. Now, but people have looked at whether having more symptoms is associated with the immunogenicity. Those are small. I'm showing 3 trials. There's actually a 4th that was just published from Framingham a week or 2 ago that was also consistent. That showed that basically it suggests that the more the systemic reactions you have, the more severe your reactions, the higher your immune response, even though it's a relatively weak relationship, but pretty consistently shown, not definitive, but suggestive, that the expression is no pain, no gain, so that the worse you feel after a vaccine, the suggestion is, if it's real, that it's and related to the vaccine, that may suggest you get greater immunogenicity with it, but still kind of questionable. There have been several studies that have looked directly at inflammatory markers in immunogenicity. And I say several, I know of 2 that have looked at mRNA vaccines or any COVID vaccines. This is one of them. The other is very similar in its findings. This just 58 individuals looking at 41 different cytokines and chemokines and the change before and after each dose of the vaccine. And I focus on, in the middle, of the interferon gamma changes that occur, a 2.5-fold change in inflammatory biomarker before the first dose and after the second dose, and then between the third dose, before the second dose, and then after the second dose, a 20-fold change in inflammatory markers. And you'll see on the far right then a moderate correlation then between the antibody response and that degree of inflammation. Again, kind of supportive or relatively supportive of the symptomatic subjective complaints. The worse your complaints, the greater immunogenicity. Now, because this is kind of, I think COVID really brought a lot of wearable sensor data to the forefront because it was it was so ubiquitous. So many people had wearable sensors. There was a lot of studies that looked at the relationship between physiologic parameters in individuals before vaccine and after. I'm going to show two of those studies, but I think there were, if I remember last time I looked, about a half dozen that have shown relatively similar findings. So what's key about these wearable sensors is they're able to detect very subtle and individual changes. So in medicine, much like we were talking about before the talk, how there's this continuous variability, but there's even greater inter-individual variability in, let's say, what's a normal heart rate. But if you know what somebody's normal heart rate is, and in this case, normal resting heart rate, and that's just one measure per day, that's determined whether you have an Apple Watch, a Fitbit, a Garmin, an Oura Ring, whatever. And then we have that. And in this study that we ran out of Scripps in the DETECT study, we had 3 months of normal heart rate before somebody had a vaccine and looked at the change. You notice in the top graphs, both in the first dose on the left, second dose of the vaccine on the right, you could detect a subtle change. And subtle is really the term. So you look at the second dose where you had a more robust response, it's a 1.5 beat per minute change in that person's resting heart rate, something that would never be recognized in a clinical setting in an episode of care, but can only be recognized because we know what that individual's normal was beforehand. On the cumulative distribution of changes in heart rate, you'll notice it was relatively subtle in most people. And again, remember, this is just a single resting heart rate per day in the days before and after the vaccine. You see about 80% of people after the second dose had a change in resting heart rate that was less than 5 beats per minute above their normal. This is just looking at the relationship between changes in heart rate and known other effects. So one known effect is people who had a prior infection tended to have a more robust, more symptoms at the first vaccine. And this graph shows the response in first and second dose in people with a prior vaccine or prior infection versus not a prior infection. You notice in the blue with the prior infection, more robust physiologic response to the vaccine that was matched on the second by none. And then also people who got Moderna vaccine tended to have more side effects after both the first and second dose. And in here, this shows the differences in individuals who got the Pfizer in blue and the Moderna in orange, and showing that there was a significantly more pronounced effect on the resting heart rate in those who got Moderna versus those who got the Pfizer vaccine. Again, I mentioned there are multiple studies. I'm going to show the second one, and last one I'll show is for the Oura Ring. So the Oura Ring, unlike the watch devices, also has the ability, or most watch devices, I should say, can measure temperature deviations. Here, the investigators looked at over just under 1,200 individuals wearing an Oura Ring pre and post vaccine. In this study, they also looked at, they did spike antibody testing on average about 38 days after they received the second dose of the vaccine, and were able to then correlate the physiologic changes they were able to detect using the ring sensor with the immune response. And they found that all of the parameters, so heart rate variability, respiratory rate, and temperature change, all correlated with the immune response, all significantly changed around the time of the vaccine compared to pre-vaccine, but showed that temperature change was interestingly the one significant marker by multivariate analysis. You should see on the graphs. All right, now I want to get into what say is physIQ's focus and has been a long-term focus even before we were a healthcare focused company. Stephan and the co-founders of the company were focused on using sensors to detect earliest deviations in complex machines like jet engines, nuclear reactors, and the like, and then have been applying that to healthcare setting now for over 10 years. This is kind of a summary, and again, Stephan can go into much greater detail since he essentially created it, of this personalized physiologic analytics, where we use real-time continuous physiologic data. So remember the data I showed you before, even though when we wear a watch and ring, it'll tell us heart rates and respiratory rates, but really during the day, you can get accurate data probably less than 10% of the time. It's really the nighttime data, and that's why you get nighttime summaries for respiratory rates and heart rate and the like. We tend to use, not only, but we tend to use wearable patch sensors where you can get continuous streaming at 125 hertz, ECG, accelerometer, and temperature sensor on the patch. All of that is meshed into 17 unique features per minute. And then those 17 features, minute features, are used to create your personalized baseline. And what we consider a dynamic physiologic digital twin. So we'll use the data from the patch to create a model for your normal physiologic behaviors. That means your heart rate when you're walking, when you're talking, when you're sleeping, when when you're doing multiple things at once, when you're at different postures. And then going forward, after the baseline is created, that your real-time physiologic performance is compared to that digital twin, your baseline performance. Then the residual is calculated, any deviations between that baseline digital twin and actual, and then those are summated into a multivariate change index that transforms the residual calculation into the scaled index of the digital twin. And that's the general overview of the personalized physiologic analytics. I'll show you an example of applying that in the vaccine population. Shown here. So this is
sorry, I was just going to add a little bit just for the data scientists in the audience.
Please.
So, yeah, the modeling approach kind of is very similar to what is done with autoencoders, with neural networks, and essentially what we're saying is if you can match the input pattern, reproduce it, then you should. If there's something anomalous in the input data, then there should be a difference between the model estimates and the actuals, and that's what we're keying in on, as Steve described. The red in the previous chart would essentially be those anomalous input patterns of differences.
Thank you, Steph. You said it much better than I ever could. You understand it. All right, so this is an example of a vaccine-treated patient. So in the study, and I'll go where individuals wore the torso patch. You can see a picture of it on the top left for 5 days before the vaccine, and then for 7 days after. I mentioned we used the machine learning method, similarity-based modeling, to create the digital twin, as I mentioned. So the graph on the below is a printout of some of the vital sign streams of heart rate variability, respiratory rate, activity, and temperature on the bottom. The digital twin estimate created at the baseline is shown in orange. The real-time biometrics are shown in blue. And you can see where the blue and the orange are deviating from each other. So an increase in resting heart rate above, not in resting heart rate, but in heart rate above what's expected, given that person's activity at that moment, time of day, and things, as well as a decrease in heart rate variability, an increase in respiratory rate, as well as an increase in skin temperature. And then those are summated into the multivariate change index, which is shown above in the maroon graph, and also in the heat map just above that. And then a lot of the group data I'll show you will focus on the heat map presentation of that. So I want to look specifically at the study and how we designed this study. So there were actually three components to it. There was the main study, which was just, as I mentioned, the 5 days patch before and 7 days after, and both under, ideally, but under both vaccines, that ended up being a small number of people just who got the first vaccine. So most of it was the second and the booster dose. We had a collaboration, and we still have an ongoing collaboration with Purdue, where they're also wearing the patch in the same way, but there's a PPG sensor, a physIQ modified Samsung Galaxy Watch before and after the vaccine that we have yet to analyze. And then we had a small immunogenicity sub-study that involved 21 individuals who, again, by original design was going to be the first and second dose. It ended up being primarily around the second and booster dose. So most people got only 3 blood samples prior to the second or booster dose, 14 days after and 60 days after, looking at both cellular immunity response and humoral immunity response. This is just the summary statistic of our patient population. We had 97 individuals, a total of 118 vaccine doses. 99%, all but one, was either Moderna or Pfizer vaccine, and those were pretty evenly split between the two. The average age was 38, and about 11% had prior COVID. So let's look at the responses that we found. This is the heat map of the inflammatory response, both to the first dose and the 17 individuals on the left, and 101 doses on the right. Going forward, I'm just going to focus on the inflammatory response to the second dose, just for clarity's sake. We're going to mention Moderna and Pfizer were split pretty much 50-50. As I noted earlier, the subjective data and everything shows that Moderna, you tend to have a more robust inflammatory response compared to the Pfizer vaccine. We found that also you can just tell visually looking at the heat maps here. We also looked at the relationship to symptoms. Now, people, when they wear the patch, there's a locked data hub. It's essentially a locked Android phone. And they were asked to enter if they have any symptoms. And so about 65% noted they had systemic symptoms. About 11% said they had local only symptoms. And then 24% had no symptoms listed. Now we know because of some challenges with the app and on whether you got your vaccine on a Friday, it didn't push the symptom questions to you on weekends. So this is a combination of people who either both didn't have symptoms and also just never entered symptoms if they had them into the phone. So it's a little bit messy on the bottom. But we broke down basically in looking at the relationship in inflammation between those who had systemic symptoms and those who did not report any systemic symptoms. We looked at inflammation in 3 different ways, looking at the total response. So essentially the area under the curve of the inflammation curve. And this is, you can see kind of explained on the bottom where people have different waxing and waning inflammatory response, usually not necessarily consistent overall. So we summated the area under this inflammatory curve. We also looked at just the response duration. How long did the individual, from beginning to end, how long did their inflammatory response end? And then we looked at peak response, at 95th percentile of all non-zero regions, and seeing if just the peak response was the best associated with subjective symptoms and immunogenicity. This is a look at those 3 measures of inflammation and the distribution shown on the top. So the total inflammatory response, the area under the curve on the far left, and the peak response on the far right, and then the response duration shown in the middle. They all correlate relatively well with each other. You notice by using these from about 95%, well, yeah, roughly 90%, 5% of individuals had a measured response in this iMCI variable, again, compared to their baseline normal. We're going to focus primarily on the total response as well as the peak response, and I'll show you part of that is because when looking at the subjective data, that you see that both having systemic symptoms versus not were significantly correlated with both the total response and the peak inflammatory response, but was not differentiated between those. The inflammation duration did not differentiate between those who had systemic and just non-systemic symptoms, either no symptoms or local. Then we'll look at the relationship to immunogenicity. Again, this is just in the heat map is the 21 individuals who were part of the immunogenicity sub-study. As I mentioned, we're gonna focus just on those individuals. There were 3 people who also had a first dose, and we're gonna exclude those just for simplicity's sake, and look at just those who had the 3 blood tests after the vaccine. On the bottom, it shows the distribution of the total area under the curve response of inflammation, as well as the peak response and overall. So unfortunately, one of the key things we're still waiting to look at is the antibody response. The assay that was done was a semi-quantitative assay, and unfortunately, since everybody peaked out at day 14 and virtually everybody at the end of the study, we can't really distinguish any differences between inflammation and the response rates. So those are still being rerun in a fully quantitative assay, and hopefully we'll have those results in the next couple of weeks, even though, to be honest, I said the same thing a couple of weeks ago. So, but Sid. We also looked at the cellular distribution or the cellular immune response. And in the CD4 is the helper T cells, and these are the T cells that help drive the immune response, help B cells, stimulate the B cells to create antibodies, as well as many other functions. The CD8 cells are the killer, the cytotoxic T cells, and will help actually destroy the virus over time. So different functions you can see, and this is consistent with other studies, a lot more variability in the response, in the cellular response after vaccines. And what we're seeing here is pretty consistent with what has been published in the area. This is looking at the total, this is specifically looking at the CD4 response in the IL-21 positive subpopulation. You notice that there's a modest correlation between the T cell response and the area under the curve, as well as the peak response, and that was most significant, especially in Spearman correlation in both. I'd say maybe a little stronger in the peak inflammatory response. If we just look at a dichotomous response, whether somebody had a positive CD4 response versus not detectable, both, well, the area under the curve would significantly could differentiate. The inflammatory response area could differentiate between those who did have positive CD4 response versus those who didn't. When we look at CD8, also showed a strong correlation, but what's interesting is an inverse correlation, which was not necessarily expected, and we haven't yet fully explained. There are some previous studies that do show that inflammation does decrease CD8 production in different settings, but it's certainly an unexpected and very exciting finding that hasn't been shown before. But like, as you can see by the plots, a strong correlation, but an inverse one. And this, similarly, we're looking at it as just a dichotomous response. Did individuals, have generate CD8 interferon gamma positive cells, or didn't they? Again, a strong correlation, but or strong relationship, but an inverse relationship. So those who did have an inflammatory response tended to not have a CD8 noticeable CD8 response, especially when we look at the area under the curve, and then less so in the peak inflammatory response. Yeah. So let me fill this out. So in conclusion, what we found so far, and we have a lot of work to do, we have a multivariant digital biomarker for inflammation that we think can capture the objective evidence of the entirety of an individual's physiologic response to an mRNA vaccine in, again, up to 95% of individuals who received it. The degree of that measured inflammatory response after vaccine correlated well with subjective symptoms experienced and with cellular immunogenicity, though still a lot of work. And so part of that ongoing work is further exploring the relationship with humoral immunity. I didn't add here, but also multiple other T cell subsets. And then also we're still refining the biomarker. We looked at just one measure for heart rate variability, and one of our collaborations with Purdue is looking at other measures of heart rate variability. And I'm hoping this will work. This will be the final slide. I just want to show this is work being done by Matt Ward in biomedical engineering here at Purdue. It's going to show the relationship between changing over time over a 48-hour period after vaccine compared to pre-vaccine heart rate variability in a relationship in percent change in high frequency power, low frequency power, and very low frequency power. And I'll show you. So you'll see a new dot over time. The dot's color correlates with temperature. And you'll see over time that now the temperature is increasing. And this is a 27-year-old male. I'll show on the other slide a 25-year-old female for comparison, and show the difference and similarities in that trajectory where you peak temperature and then kind of dogleg and start returning back. And we think that this will have the ability, and I should say the size of the circles is related to the heart rate corrected SDNN measure of heart rate variability. So there's a lot of information we think still hidden in various measures of heart rate variability, and we're doing a lot of work to try to refine that and include that in the digital biomarker. So that is all I had. I will stop sharing, and Stephan, in particular, I would be happy to answer any questions if there are any.
That was fascinating. It couldn't have been more apropos.
Great.
And I mean, of course, the danger for somebody giving a talk like this is everyone talks about their personal medical experience, right?
Yeah.
So
That's
we've
great.
all been through this. Having just gotten a booster shot yesterday, I was thinking, I'm worried that I'm not feeling sick.
Yeah.
So
Well,
I noticed you headlined interferon gamma as opposed to say IL-2 or IL-6. Do you find that that's a better surrogate, or is it just that's what you were measuring, or
it's what we've analyzed so far. So that's it. And we work. I should have called them out on the slide. On the first slide, we work with Cell Carta out of Montreal, Quebec, and with the immunologists there. And so when we were kind of on a timeline to try to do best analysis, we just started with interferon gamma, but are planning on looking at all the other cytokine markers.
that enormous variability in the cellular markers between individuals was also really. We have what 10 to the. Do you have 10 to the third typical variability fold chain? I mean, it's enormous.
Yeah, and maybe a week or two ago, a paper came out that showed that, especially for young individuals, that even after a booster dose, they had no measurable change in the T cell. And their conclusion was, well, because they've already got adequate population. And again, I apologize, that's the cardiologist's understanding of it. For those, no, but so I think there's just a lot that we still need to learn with that, and I don't.
And I was just going to add the dynamics as well. I mean, we have a measurement at day 14 and end of study, but who knows where the peaks occur? It's different for everyone, and so is the inflammatory response, which is why we look at this as a multivariate type problem from a wearable sensors point of view.
Well, I think one of the things we've been banging our heads against coming from where we do, a lot of us do, is that the kind of data that you're pulling, it's very interesting to see you using the kind of data that you really can get continuously. Because we're all sitting there thinking, what we really need is cytokine levels every 5 minutes, which aren't going to happen.
Yeah.
On the other hand, it's an issue because, as you were pointing out, the blood pressure could change quickly, the heart rate could change quickly. Cytokine levels can change have multiple fold change in 20 minutes. And so when you took your blood sample, if you're only taking it every 2 weeks, better than nothing. But boy,
Yeah.
it's not showing you that high frequency dynamics in cytokines that we know are there. But here I said I'd introduce. I try not to ask questions until I've given the floor a question. It's not fair. So let me turn it over to everyone else for discussion. I can come back to it.
I can jump in with a quick one. If this is a clinical trial for all intents and purposes, so I'm sure it's quite expensive. What do you think the minimum cost per person would be in a non-trial setting? So how much for a Fitbit that would be adequate? How much for software on a pre-existing smartphone? How much for some way to log and analyze the data remotely? Some way to work as part of a cohort so that not only are you feeding your data, you also have some access to anonymized data from people that live around you, other populations, age, sex, gender, race matched, location matched, or in the same town. So can you give a rough estimate of what you think that would cost per person?
Yeah. It's a good question, and it's a hard. So it really depends on what, like, if we want to do the medical grade sticker and what we do, or like the detect study, the aura study. Those things are volunteer, but the challenge with that is you get especially when you're starting with the bring your own device, people already have it. You get a skewed population that tends to affect diversity. But the work we did at Scripps was actually to try to specifically focus enrollment on improving diversity, and we showed in a small subgroup you can. So there are ways to do that. But the problem with a lot of the commercial wearables, which are going to run, let's say, several $100s, depending on which one you want, is you're still going to get the kind of more limited data. You'll get the one data point per day, not with activity and sleep, which is good for measuring impact, let's say, of the reactogenicity, the symptoms of it, but not the robust data. I don't know, Stephan, do you have a physIQ kind of breakdown of?
Yeah, unfortunately, I'm not a sales guy, but I will say, for the patch, we know, typical 7-day patch is around $60. So that gives you a feel for the cost of a patch. But of course, our platform and all the infrastructure around that costs money. So I would say you listed so many variables there that to try and give a rough estimate, it would be tough. But let's say we were doing, I don't know, a month-long study, and we were using the patch, and we were collecting data from a questionnaire using a phone app. My guess is that would be somewhere around $500 a participant. I think that as a very rough estimate, and hopefully my salespeople won't hear this. But
Well, I guess
in a clinical trial setting, $500 for a person for a month is, that's a rounding error.
Yeah.
In a clinical trial.
Yeah.
Okay. All right. Thank you.
I was going to say, Jim, after I had COVID in the summer when I was feeling crappy, I got cardiologist stuck one of the stick-on EKGs on me for a month. And the usual and customary that they billed were $400 for that month of monitor, which seemed pretty reasonable. It also, I smiled when you were talking about the self-reporting, because I'm sure that EKG monitor was measuring every 5 minutes and sending a great data in. but the self-reporting of shortness of breath, lightheadedness, and so on, it was so frustrating to use that phone app. I tried it once
Yeah.
and I gave up. I never reported any of the subjective symptoms
Yeah.
because it was too, you'd try to use it and it would turn off the monitor, or the user interface. It was fantastic in terms of reporting. It worked flawlessly for a month. But having to actually have the person type things in the phone, that aspect there was not great for that particular app.
Yeah.
I think it was a Boston Scientific device.
And unfortunately, none of them are very good. You know, a lot of the devices just say press a button when you feel something. And then, you know, by the time you sit down and talk to the patient, I don't remember what happened then when you did that. And sometimes they're just pushing on it to adhere it better, and they end up pushing the button. And yeah, I haven't seen a good solution for that to capture good subjective data at the same time.
I would say one thing nice about we have a phone app that we can customize for various questionnaires. But what's nice about it is you can actually remotely deploy. Let's say you have a questionnaire defined and it's just not working. You can then, while the phones are in the field, literally update them. So we try to make them simple so that, you know, you choose, I feel bad, 1, 2, 3, 4, 5 by, you know, the severity is this level, or, you know, that kind of thing to make it a little more quantitative. But it's still, and we have a study, a military study, where we're looking at COVID and COVID positive and non-positive, and we're assessing symptom severity using an instrument called FluPro, you know, and this was used in influenza, but we modify it to be, you know, more relevant for SARS-like infections. And we're just constantly shocked by how the subjective noise, how bad it is in a lot of cases. You know, we can see clearly an inflammatory response or changes in physiology that reflect, you know, that they're not feeling well. Yet they'll say, "Oh no, I feel completely fine," and that could be that they're, you know, not lying, but maybe not being totally truthful, or maybe, you know, there was an error in the entry, like you're saying.
Or they just, people have different judgment about what's significant, because
Yeah,
typically questionnaires will say, have you ever X? And
Yeah.
they don't really mean have you ever X. I mean, have you significantly had X, which is not the same thing. And what the subjective threshold for what's significant, what is meaningful is different between people.
Well, and that's true. And then, you know, we had a questionnaire about comfort for wearing a adhesive patch, and the question was something like, did you, during the study, did you feel irritation? Well, if you say yes, that could mean, okay, for 10 minutes at one point, you know, 3 days ago, I felt some irritation. But what we're really after is, are you feeling irritation nonstop? And yeah, and so there's that issue too.
Yeah, it's hard to ask those questions in a precise way that everyone agrees on what the standard is.
Yep.
And that was a question asked for the wearable I had. And I mean, yes, once or twice it got bumped or it was itchy, but in fact, for a month it was remarkably, you didn't know it was there.
Yeah.
So I would have answered no, but in fact, if the threshold was, have you ever had any irritation at all? Then the answer would have been yes. So the question, well, you're doing area under the curve, peak, and duration. So you're at other kinds of metrics. So it's basically the same thing for the non-subjective data about what features are you looking for?
Right, and how strong of a response? Yeah, how do you measure strength of response? And that, you know, it's tricky.
Do you are you planning what's your goal with the patch? Is that do you plan to sell that like a, you know, Fitbit like device that people would want to wear?
Well, we don't actually make devices, so we partner with the company that makes the patch.
Okay, I see.
So they're our supplier, and we have another patch company that we work with too that makes they're called VivaLink. They make a rechargeable version of the adhesive patch.
Mm-hmm.
And what I think going forward, what we'll probably see more and more of is sort of a hybrid type approach where you use the patch at the beginning to get really high resolution, high quality data for baselining, and then you could use for much longer term monitoring a typical wrist device that has PPG and accelerometry and temperature on it. So.
Yeah, that makes sense.
So,
Thanks.
yeah. We are built to be device agnostic, and which I like, because I think that in fact, when Stephan, helped start the company, they created their own wearables because there wasn't anything. And you look at how much everything has changed in the quality and the availability. And so our goal is to let smart people develop the devices, but for us to have the platform to ingest the data, to track it, and to analyze it.
Yeah, I wear my watch and I have the cardiogram thing, and so I get data that shows my heart rate for 24 hours a day, every few minutes, when I'm wearing the watch anyway, and like that's free data. I can't do anything with it because it's just a big table of numbers.
Yeah.
That's kind of problematic. But I do try to go back in and look at when I took a blood pressure, or if I go and I look at the cardiogram stuff, is the heart rate anywhere similar to what my blood pressure cuff said? It's just because I'm just digging around playing. Have a question about the response to the vaccines. Is there enough of a central tendency, commonality in the sample response that you're able to pick out outliers, that overall there's a general trend that most people follow, but it's very apparent that this one individual did not do that? Are you able to make those distinctions that would enable you to pursue the understanding of the outlier?
Yeah,
What's different about that person that they did not respond the way the average was?
Yeah, well, and what's interesting is you do see a lot of variation in how people respond. Generally speaking, there's an increase in heart rate, increase in respiration rate, but the timing of those things can be different. And so the iMCI thing that Steve showed is implemented in a way that kind of takes advantage of the expected patterns that you would see in individuals. And so if you're not matching that, you'll catch that outlier. We'll see in a different version of MCI that their physiology has changed a lot from baseline, but it's not matching the thing the pattern that we're looking for that we think is indication of inflammation. So it allows us to identify those cases. Now, have we gone through and identified cases and then tried to figure out what it is about what their genotype that made them respond the way they did? We haven't done that, but it's possible to identify the outlier cases and to be able to do that.
I mean, and that's really kind of. Go ahead, John.
Go ahead.
I was going to say that's really kind of one of the hopes. There have been studies looking at people in the immune response who have hematological malignancies or immunosuppressive therapies, and we know those people don't get an immunological response. And we know that in general, younger people, females tend to have a more robust response than older people, but it's everybody still gets the same dose, same regimen, and so partially that's driven by kind of a lack of any kind of scalable biomarker to show if somebody responds acutely, and that's what we kind of hope as we learn more about this biomarker and can refine it better, that's one potential use for it.
So you didn't try to talk about stratification by age. I think maybe you did, but I didn't see. I guess with 100 patients, you don't have that many.
Yeah,
you can't do age correlation. Did your study design eliminate people who were taking an antihistamine, eliminate people who were using an inhaled steroid or something like that, or was that not a admission criteria?
We tried to be pretty pragmatic about it. The only people we excluded who were on chronic oral immunosuppressive, like oral steroids, and otherwise we captured whether they were taking especially in response to the vaccine, if they took an antipyretic or an anti-inflammatory afterwards, and have yet to look at it, like you mentioned, it's a small sample size, and it's kind of hard to slice and dice through it in that way.
But if you saw a clear stratification there, that would be really important.
I totally
If you
agree.
get guidance, you have to go off your inhaler a week before you're at your vaccination. Those kind of things could be really have big effects on the population level.
Yeah. So I think I think everything you bring up is what I hope this can kind of lead to. You know, there have been studies that show the amount of sleep before you have vaccine affects the immunogenicity. There was a study recently that suggested the more active you were after a vaccine, the greater your immunogenicity if you went out and exercised and stuff. So I think, you know, it's a lot of what I think is a lot of kind of population-based medicine, which is what we practice too often. It's kind of like, well, you know, be yourself, get a vaccine, and then we'll see what happens and see if you get an infection or not somewhere down the line.
I mean, one thing that using the position where you are with commercial vaccines that are already out there, you can't do so much. And goes back to some talks we had very early in this series 2 years ago, was on adjuvants.
Yeah.
And it really would be interesting if you could get in early so that somebody was doing a vaccine development where they were looking at different adjuvants for the vaccine. And then, and something you already preempted, which was you're not doing the quantitative antibody yet. And so something that also is of course discussed a lot maybe a year ago was not only what's the peak antibody level, but what's the duration? Is there anything you could do that changes the lifetime of elevated antibodies?
Yeah.
And it's not obvious that anything happening early would do that. But if you had a signature early that predicted, gee, your antibody decay rate is, you know, your half-life for the antibody is 2 months versus 1 month versus a month and a half, and you had early signature for that, that would also be incredibly useful.
Yep. Totally agree.
Other questions? John, I didn't mean to cut you off. Jim, same.
Oh, yes. Do.
I mean, the other thing that you're doing here, which I like to see, which we've addressed, which has come up, which is you're using essentially you said you're using autoencoders for that. But one of the problems we have even in the mechanistic world that we live in, the modeling world we live in, is that you have stochastic models. And the patient is also stochastic. And so you have one patient time series and you have a series of stochastic predictions.
Mhm.
And you don't have an obvious way. You can't just do a mean squared difference between the time series. It doesn't mean anything. And so if one can develop some kind of AI-based classifier that actually does give you some degree of membership or similarity that's meaningful, without that, you can't do anything in terms of optimization, regression, you're stuck.
Mhm.
And so one of our biggest problems is the lack of ability to compare predicted time series to experimentally or clinically observed time series. And to see that time series where you had your digital twin pairing there was very interesting. Now, those are slightly simpler in some ways than the time series that typically we work with.
Yep.
But the fact that you could do that at all, I think is a very important proof of concept.
Well, and that, you know, that comes from, as Steve mentioned, my prior life when we were monitoring complex industrial equipment, and before that, nuclear power plants and, you know, reactors, and it's a tough problem. If you can come up with, there are first principles models that are good for modeling and doing design work. For detecting very subtle indications of problems, they're just not sensitive enough. There's too many assumptions. There's too many you make something linear that's nonlinear and things like that, where that's really sort of the genesis of this approach. Is we needed a way to say, okay, the sensor data is describing how this system really behaves. Let's learn from that and make that the representative model of it. And then, of course, with humans, everybody's different. So, the personalization is key there as well. So.
I guess you'd hope with a jet engine that there isn't that much stochasticity when the engine is behaving properly.
And you'd think that, and gee, we went up against GE and their own engine maintenance people, and it was the same issue, the same model, but the instant was different, and different enough that they couldn't detect as early as we could slight damage on turbine blades. So it's really interesting.
That's very interesting. We'll have to get our GE friend back to respond.
Yeah, that would be fun.
That was one
and
of the
actually GE ended up
had early on was one of the GE digital twin people. So
that's
he inspired us a lot.
Yeah, and Smart Signal was my prior startup, and GE bought Smart Signal, and then they changed the name of that technology to digital twin. So that's where that actually comes from.
Well, they have it easy. I mean, the system is operating in an environment that they build the system and they tell you what temperature you have to maintain around the system so that the system's going to perform the way it does, humidity, all that kind of stuff. If there's a range of variability it has to operate in, what that range of variability is. And at any given minute, you can tell what the actual is. You take the human immune system, the environment of my human immune system is all my other human systems.
Yep.
None of which can I specify, nor can I probably measure, much less control with any degree of accuracy to have a digital twin of the immune system as it functions in the environment of James. Because all of his other systems don't standardize.
Yep.
And so I don't know how you guys are ever going to do this. I hate to have to leave, but I do.
Well, we've had a good discussion. Are there any last questions for our speakers? John and I sort of monopolized the conversation today. I really wish Gary Ann were here today, because as a clinician, I think he would have loved to respond here. He's always has a laser focus on what he could do to improve clinical outcomes. He's also a modeler and does both mechanistic and machine learning methods. So he's got both hats, but he's our of the sort of the standard regulars here. He's the one probably with the most single-minded focus on what can we do to improve clinical outcomes, and how to use these technologies.
Yeah, and our part of our business, we do a lot of work in clinical trials, but we also have built a solution for healthcare delivery for that very reason. And so we have some applications in heart failure. Heart failure is tricky. I mean, people just that their physiology is so complex normally, and then you throw a heart failure on top of it. It's, of course, Steve can talk a lot more about that than I can, but yeah, we think this is very valuable for monitoring individuals with chronic illnesses or undergoing chemo or CAR T therapy, for example.
Well, that's a good one for your rare events, because you have these people who die from CAR T,
Yep.
and they can't stratify them at the moment. They don't have any way. You talk to you're at Indiana now, so right? You talk to our immunotherapy people in the med school, and they're desperate for some way to predict who's going to die when they give CAR T.
Yeah.
They just don't have any way of predicting those adverse outcomes.
Yeah.
Calvin Lee would be those sorts of people.
Okay.
Well, that was really great. I really appreciate it. And
No, thank
yes,
you.
I look forward to seeing how
For
this
having us.
develops. I hope maybe you could come back and give us another talk in a little more detail, because I think there's so many issues that you've raised and you've worked on so many aspects of this. Because I think also just maybe it's not unfair to you because it would be didactic, just helping us understand the translation from going from industrial digital twin application to medical digital twin.
Mhm.
What were the key things? I mean, industrial digital twin, at least there is a blueprint. You have some idea that things should be the same, even if
And
they're
you could
not.
put a sensor wherever you want.
Right. And you could do a lot more instrumentation. And
Yeah.
so, I mean, we always come back to this, you know, if the wearable could do blood chemistry, everything would be different. But, and I know there are people up at Notre Dame who claim that they can do wearables that can do some blood chemistry.
Yeah, even Massimo was claiming they had with their rainbow technology, they could do that with PPG sensors.
So, but maybe, you know, ask the question, what would, if you were going to develop one sensor technology, we would tell ARPA-H, this is the sensor technology we need. What would it be that would be most
It would
enabling?
be the Star Trek tricorder.
Well, but that's everything. That's asking for everything. So I'm saying if you could make one measurement, one more, what would your priority be?
Breath analytics.
What was that, Steve?
Breath analytics.
You have somebody at Purdue doing that. What's his name?
Yeah. I mean, I just think it's kind of this untapped thing where it can tell you everything that's going on. Now, you'd have to be able to do it more continuously and measure changes, but I think that's, you know, compared to like sweat or tears or everything else, you know, I'm a big fan of physiologic biomarkers, but, you know, I think to really, you know, I'm impressed by what dogs can figure out about us that we have no idea what, you know, by their sense of smell. And it seems like there's a lot of untapped potential there.
Yeah.
Well, thank you again, then. I appreciate it very much. This was, I learned a lot, and I appreciate your taking the time to talk to us.
Thank you for the invitation. We appreciate it.
Yep.
Everyone have a good day.
And since you're not so far away, maybe we can actually see each other in person.
That'd be great. I'd like that. Sure. Thank you.
Goodbye.
All right. Bye, everyone.